This lecture is going to cover a couple of different types of inflammatory conditions that affects the nervous system. The first inflammatory condition we're going to look at is meningitis. This is when there is an acute inflammation of the meningeal tissues that surround the brain and spinal cord. It occurs most often in fall and winter and early spring. Older adults and persons who are debilitated are more often affected by this than the general population. Individuals such as nursing home residents, homeless shelter residents, also college students living in dormitories, and individuals living in institutions such as prison. These are going to be considered high-risk individuals for contracting meningitis, as these are individuals that live in close, confined environments. Meningitis can be bacterial, it can be viral, or it could be fungal. Bacterial meningitis is considered a medical emergency. Untreated bacterial meningitis has a mortality rate near 100%. If an individual slips into a coma with bacterial meningitis, that is usually associated with a very poor prognosis and does occur in about 5 to 10% of bacterial meningitis cases. Complications associated with meningitis consist of, first and foremost, the risk for increasing intracranial pressure. This is a major cause of the altered mental status, oftentimes noticed in patients with meningitis. Other complications of meningitis include headaches, which can occur for months after the diagnosis of meningitis until the irritation and inflammation have completely resolved. It's important that we implement pain management for chronic headaches as part of the overall plan of care for the meningitis patient. They're also likely to have some residual neurologic dysfunction. Oftentimes, the optic nerve can be compressed due to the increased intracranial pressure. The patient can experience ptosis, unequal pupils, and diplopia. This occurs due to irritation to cranial nerves 3, 4, and 6 as well. We can also see irritation of cranial nerve 7, the facial nerve, which can cause problems with facial paresis, and problems with the vestibulocochlear nerve, which can cause tinnitus, vertigo, and even potentially deafness. If the patient with meningitis does experience the complication of deafness, it's possible that the hearing loss can be permanent. Hemiparesis, dysphagia, hemangiopias are also some other complications that can occur in your meningitis patient, and these do have the potential to resolve over time. The patient experiences acute cerebral edema. They are going to be at risk for seizures, can even experience bradycardia, hypertensive comas, and in worst case scenarios, death. DIC and shock are some of the most serious complications of the patient with meningitis. When we look at the manifestations and the diagnosis of meningitis, we're going to look at viral meningitis and bacterial meningitis separately, and we are going to talk about them together as well. And regardless of whether it's bacterial or viral, we do tend to see a similar set of symptoms with a few minor differences. And we also can see some differences in the diagnostics related to it being viral versus bacterial. However, the complications, as mentioned in the previous slide, have the same potential in either form, with the exception that they are more likely to occur with bacterial meningitis, and bacterial meningitis is considered the more dangerous form of the two types of meningitis that we're going to talk about here. One of the differences that we're going to talk about between viral and bacterial meningitis are the results of a cerebrospinal fluid sample. Diagnosis of meningitis is verified by lumbar puncture and analysis of the cerebrospinal fluid. The lumbar puncture should only be completed after a CAT scan has ruled out that an obstruction of the foramen magnum is not present, in order to prevent fluid shift that could result in herniation. One of the first differences that's noted between viral and bacterial meningitis on examination of the cerebrospinal fluid is its appearance. Viral meningitis has cerebrospinal fluid that can appear clear to slightly cloudy, versus bacterial meningitis, where the cerebrospinal fluid sample appears cloudy to the point of being turbid or even milky. You'll notice that the white blood cell count in the CSF sample is about 25 to 500 in viral meningitis, but it's usually greater than 1,000 with bacterial. We'll also see that the protein level is much higher with bacterial meningitis. The glucose level will be normal to low in viral meningitis, yet decreased in bacterial meningitis. Some other differences that we notice is that although both patients can experience a headache and a fever, the headache is generally not as severe with viral meningitis as it is with bacterial, as well as the fever. They're going to have a lower grade fever with viral meningitis and usually a much higher temperature with bacterial meningitis. Other tests that would likely be done on the patient would include CAT scans, as previously mentioned, in association with the lumbar puncture, even blood cultures, some other types of blood testing that can help to diagnose any other type of potential central nervous system infection. Other symptoms that may be present in the patient with meningitis include nuchal rigidity, or stiffness and pain in the neck, which is a common symptom associated with meningitis. We can also see Koenig sign and Brudzinski sign. This is oftentimes found in children. Koenig sign is when the patient cannot extend the leg at the knee when the thigh is flexed because of stiffness in the hamstring. Brudzinski sign is that when the patient's neck is flexed by the practitioner, their hips will automatically flex at the same time. This is usually a reliable indicator of meningitis after the age of 2. Another condition that we can see, or symptom that we can see, is what we call arcing. This is sometimes present in infants, is when there's an involuntary arcing, spelled like the arch, A-R-C-H, involuntary arcing of the back and extension of the neck. Another term for this is opisthotonos, and this does indicate that there's meningeal irritation or a potential brain injury. Other symptoms included in meningitis consist of a rash or petechiae, photophobia, a decrease in level of consciousness, increase in intracranial pressure, as mentioned, as one of the primary complications. So all of the signs of increasing intracranial pressure can also be symptoms present in the meningitis patient, and the risk for seizures. A headache, as mentioned already, is present in both viral and bacterial types of meningitis. As mentioned, again, as not as severe in viral as it is in bacterial. However, headaches are known to become progressively worse and can be accompanied by vomiting and irritability. Seizures are generally seen in about 1/3 of meningitis cases. When it comes to the care of the patient with meningitis, a priority consideration is placing the patient on droplet precautions. This should be one of the first actions taken if meningitis is even suspected in a patient. We need to make sure that we protect everyone caring for the patient and everyone around the patient from any further potential spread of the disease. If meningitis is suspected, blood cultures will be drawn, and then the IV antibiotics are going to be started regardless of whether or not we have those results back yet. But those samples, like the blood cultures and the lumbar puncture, needs to be done prior to the administration of the antibiotics. If those cultures come back negative and determines that it is viral, then the antibiotics can be stopped and only supportive care would continue, because with viral meningitis, it is considered self-limiting and a full recovery is expected with the patient. However, if it is bacterial, then several different types of antibiotics are recommended for the treatment of bacterial meningitis, such as ampicillin, penicillin, vancomycin, to name a few. Cephalosporins are also a common group of antibiotics that can be used in the treatment of meningitis. Steroids are also going to be prescribed to help decrease the inflammation associated with the condition, and it may be prescribed even prior to the first dose of antibiotics or right along with it. Some antibiotics will require monitoring of the therapeutic blood levels depending on what is prescribed for the patient. So peak and trough blood level monitoring may be necessary to institute as well. If the patient did have bacterial meningitis, then prophylaxis is going to be needed for any individuals that did come into close contact with the patient with the bacterial meningitis. Other care considerations for the meningitis patient obviously is going to be to provide pain relief to the patient for the head and the neck pain. We're going to assess their vital signs and their neurologic status on a routine basis. We're going to want to make sure that they're in a position of comfort. Oftentimes this can be curled up with their head slightly extended. The head of the bed should be slightly elevated when permitted after the lumbar puncture. Obviously, this is going to help minimize the risks of increasing intracranial pressure. The presence of a familiar person at the bedside can have a calming effect as well. It's typical for them to be hypersensitive and have some mental confusion. So we have to be caring and unhurried in care of the meningitis patient when we are providing care. We may likely see them get a prescription for some anticonvulsant medication prophylactically because of the risk for seizures. So we're going to want to institute seizure precautions for this patient as well. When it comes to management of the fever, we do want to be aggressive in the fever management. Generally, it's going to require a little more than your traditional acetaminophen or ibuprofen therapy. They oftentimes may need a cooling blanket, but we do need to be careful not to reduce their temperature too rapidly, because if we do, we can cause shivering. And if we cause shivering, we can actually create a rebound effect where the temperature actually increases. Another option is that we can wrap their extremities in towels or blankets to help reduce their shivering. Another reason for the concern for the shivering is not just that we don't want to cause a rebound temp, but we're also trying to manage that risk for increasing intracranial pressure. So if the patient begins to shiver as a result of our attempts to reduce their fever, we can increase the risks for increasing ICP. We can also try, if we don't have access to a cooling blanket, a tepid or lukewarm sponge bath can be effective, but we don't want to give a cold bath. We do want to make sure that we protect the skin from any excessive drying that they may experience, which can cause breaks in the skin. And know that too, another reason for management of that fever is that not only does it increase the risks for the increasing ICP, but it also increases the risks for seizure activity, and neurological damage is a potential problem from a high prolonged fever. Some other things that we can do is keep them in a darkened room with a cool cloth over their eyes. That can help to manage the photophobia. Again, as I mentioned earlier, keeping a familiar person at the bedside is good for the environment, but we do want to generally minimize their environmental stimuli. So keeping the room calm and quiet is going to be best practice for the meningitis patient. One of the best methods of management for meningitis is through health promotion or vaccination against respiratory infections that are most likely known to cause the different types of meningitis. Haemophilus influenza B, or Hib, used to be one of the most common causes of bacterial meningitis before the Hib vaccine. This was the leading cause of bacterial meningitis in children under the age of 5. Pneumococcus is another common cause of bacterial infections in children and adults, including meningitis as well as pneumonia and sepsis, and that necessitated the development of the pneumococcal vaccine. Meningococcus, though rare, can cause overwhelming sepsis and meningitis as well and be fatal within 24 hours. So this particular type of bacteria, again, triggered the need for the meningococcal vaccine. Some other health promotion considerations would be early and vigorous treatment of respiratory and ear infections, as these can lead to meningitis if left untreated. In addition to the Hib vaccine, the pneumococcal vaccine, and the meningococcal vaccine, also vaccination programs for pneumococcal pneumonia and influenza are also very important, and getting those on a routine basis as instructed by the CDC. We're going to take a minute just to focus on the meningococcal vaccine a little bit more. There are 2 types. There are the ones that treat the 4 different strains, A, C, W, and Y, and then the one vaccine that treats the serogroup B. So if you look at the first bulleted point there under meningococcal vaccines, you'll see that MenACWY, that's 4 different strains of meningococcus. And then the other two, MPSV4 and MCV4, both contain the number 4. So these first 3 that are mentioned here are all different types of pneumococcal vaccines that will cover the 4 primary strains that cause about 70% of the cases of bacterial meningitis here in the United States. Then there is the MenV vaccine. This is a newer vaccine, and it's only going to cover those types of meningitis that come from meningococcus serogroup B. One of the first 3 that cover the 4 different strains, those are the ones that are required vaccinations. They are required in a 2-dose series. They should start in adolescence between the ages of 11 and 12. They should have their first dose or around 6th grade. They should have their second dose or their booster around age 16 or their senior year. Between 2015 and 2017, many states began requiring the meningococcal vaccines for attendance in public school. However, the ones that cover the 4 serogroups are the only ones that are required. Most requirements were implemented before the serogroup B meningococcal vaccine was available here in the U.S. So the focus in the public school system is on one of those 3 mentioned in the top bullet. You do not have to know their names, but the easiest way to recognize that they're the ones covering the 4 different groups are that they, obviously ACWY has 4 initials in it, and then the other 2 have the number 4 in them. Another health promotion consideration is the administration of prophylactic antibiotics for anyone who is exposed to somebody with highly suspected or confirmed bacterial meningitis. These should be individuals who maintain prolonged close contact with the individual, generally 15 minutes or longer in a radius of 3 feet, within 3 feet. Encephalitis is our next type of inflammatory condition of the brain that we're going to look at. This is a viral infection that causes acute inflammation of the brain. It can be caused by several different types of viruses. There is both epidemic and non-epidemic forms of encephalitis. Ticks and mosquitoes are known to transmit certain types of epidemic encephalitis. West Nile probably being one of the most common ones that people have heard of. Non-epidemic encephalitis occurs as a complication of another disease process, oftentimes such as measles, chickenpox, or mumps. It can also come from the herpes simplex viral infections as well. Generally, encephalitis has a non-specific onset for the symptoms. They usually start out as flu-like symptoms. The individual may complain of a fever, headache, some nausea, and vomiting. Signs and symptoms of encephalitis appear over a 2 to 3 day period, and they can vary from some minimal alterations and minimal discomfort up to significant changes in their mental status and even progressing into a coma. Virtually any type of central nervous system abnormality can occur, including hemiparesis, tremors, seizures, cranial nerve palsies can be a problem, personality changes, memory impairment, amnesia, dysphagia. You get the idea. We can see any spectrum of central nervous system abnormalities accompany those non-specific signs and symptoms with encephalitis. Early diagnosis and treatment is obviously going to be essential for the most favorable outcome. West Nile virus is going to be most commonly occurring in adults, usually over age 50, who develop some type of encephalitis in the summer or early fall. The best diagnostic test for West Nile virus is a blood test that is capable of detecting the viral RNA in the test, so that's something that would be done. As well as several other different types of diagnostic studies to rule out any other possible cause for the CNS alterations that may be occurring in the individual. As far as the care of the patient with encephalitis, the nursing management is primarily symptomatic and supportive care, including the West Nile virus infection. It may be necessary for intensive care for a short period of time, and Also, they will use antiviral therapy in the management of encephalitis. Medications like acyclovir is a preferred antiviral therapy. It has fewer side effects than some of the other types of antivirals in the treatment of encephalitis. The other consideration here in the treatment protocol is prevention. Prevention looks at controlling environments where mosquitoes are known to be at, such as rain gutters, anywhere where water is allowed to collect and stand. So bird baths, low-lying areas in a yard. This is going to be areas where mosquitoes can breed. In addition, the use of insect repellent should be used on a regular basis during mosquito season. All right, we're going to take a look at Reye syndrome. I'm sure that you've heard about Reye syndrome before because you've talked about it in pharmacology classes in relation to the administration of aspirin in children, and that this is the reason we do not want to give children aspirin. But hopefully today you can have a better understanding of what Reye syndrome, the disease itself, actually looks like. It is defined as a toxic type of encephalopathy that is associated with other characteristic organ involvement. And that characteristic organ involvement is generally the liver. Most cases of Reye syndrome do follow a viral illness such as an influenza, gastroenteritis, or even a case of varicella. The cause of Reye syndrome, though, overall is not well understood. What we do know is that it involves acute encephalopathy and fatty changes that occur in the liver. We also know that it most commonly occurs in children, usually under the age of 15. We know that there is an association between aspirin therapy for fevers and the development of Reye syndrome in children, which is why the recommendation came out in the 80s to stop aspirin therapy for children. The symptoms of Reye syndrome include fever, profound impaired consciousness. This can be lethargy, it can be irritability. Children with Reye syndrome oftentimes even become combative. They're very confused. They're likely to suffer from delirium. Some other things that we see with them is that they'll have a tendency for profuse vomiting. They are at risk for seizure activity and can even progress into a loss of consciousness. In addition to that, they will have noted impaired hepatic function. So as far as diagnosis goes, we're going to use the liver enzymes and elevated LFTs as one component of the diagnostic process. In addition, a liver biopsy can confirm that there are going to be those changes present in the liver, whereas a lumbar puncture would also be done just to rule out meningitis. But the liver biopsy is what would give us confirmation that those changes were physically present in the liver that were consistent with Reye syndrome. Other things that would be done, obviously, would be to check the serum ammonia levels. We would expect those to be elevated because of the liver changes. We would check their electrolytes as well, and we would expect alterations in those due to cerebral edema developing from the encephalopathy and those liver changes. We can also expect, if we were to test the coagulation times of the child, that those would be extended as well, again, related back to the liver impairment. Treatment and management of Reye syndrome is going to focus on, one, getting an early diagnosis and aggressive management of the symptoms, mainly focusing on the potential for increasing intracranial pressure. So any signs and symptoms that we've talked about previously with increasing ICP are things that we're going to watch for in this kid. We're going to want to keep their head of the bed elevated in a neutral position. Again, management of that increasing ICP. They're probably going to get some mannitol if they begin to exhibit increasing intracranial pressure. They're going to be on seizure precautions because of the risk for seizures to occur. They're probably going to get some vitamin K to help manage their help improve their clotting process. The prognosis and recovery is good, even in view of the gravity of the disease, as long as early diagnosis and aggressive treatment of those symptoms is carried out. With that aggressive treatment and management, the client is going to be able to regain, most clients regain full function of their liver. However, it is possible, if anything, they may have some residual neurological deficits as a result of having had Reye syndrome. Guillain-Barré is another acute inflammatory disease that attacks the peripheral nerves. And this is considered to be an autoimmune type of disease. There is an attack on the myelin sheath, which insulates the nerves, and it results in demyelinization, or a loss of that protective insulation around the nerves. It oftentimes presents as an acute paralyzing type of illness that has been preceded by another type of infection. Some examples of other types of infections are listed here, such as a cytomegalovirus, Epstein-Barr virus, just to name a few. Some people also develop what we call GBS for short after some other type of event, like maybe an immunization, some type of trauma, or even something such as a bone marrow transplant, for example. The primary feature of GBS is progressive, symmetric, ascending muscle weakness. So this means that it's going to start at the bottom, start at the feet, lower extremities, and it's going to work its way up. It's also going to work its way up in a symmetrical fashion, meaning it's going to affect both legs at the same time. And that progressive muscle weakness is going to get worse in the lower extremities as it's then going to make its way up to the upper extremities and the torso. Severe weakness of the lower extremities and possibly even the upper extremities, along with depressed or absent deep tendon reflexes, is found in 90% of all patients presenting with GBS and in patients with disease progression of GBS. Some other symptoms that we see is the fact that GBS can progress to the point that it causes severe respiratory muscle weakness in the most extreme cases of GBS. And if the patient's condition does reach that point, it can necessitate ventilatory support in order to keep the patient alive for a period of time. Respiratory muscle weakness presents in about 20 to 30% of the patients with GBS. Facial weakness is also something that we will see, as well as oropharyngeal weakness. We see this in about half of the patients with GBS. There's also some ocular motor weakness that comes in about 15% of the patients. And then another consistent feature that we see with GBS is what we call dysautonomia. Dysautonomia is a term for malfunction of the autonomic nervous system. This particular set of symptoms occurs in about 70% of the patients. Symptoms of dysautonomia can include tachycardia, which is one of the most common symptoms that we see, problems with urinary retention, alternating hypertension and hypotension. We can see ileus, problems with sweating. It's important to recognize when severe autonomic dysfunction is potentially occurring, because occasionally this can be related to sudden death in an individual. So we have to recognize these malfunctions of the autonomic nervous system occurring and watch them very carefully. Diagnosis is most often based off of the history and the physical, and looking at the presentation of the symptoms, how they occurred, in what fashion and in what pattern, and any history of any recent preceding infections, as mentioned earlier. They also would do a lumbar puncture. They would find that the white blood cell count would be normal, unlike what we would see with meningitis. And we would see some elevated protein in the cerebrospinal fluid sample. The disease itself progresses through 3 phases. We call them the initial phase, the plateau phase, and the recovery phase. The initial phase is where we see the rapid worsening of the signs and symptoms. This can be anywhere from a few hours to a few weeks that the patient goes through the initial phase. Generally, it is no more than about a 3-week time frame in which the patient continues to get progressively worse and new symptoms continually appear. The initial phase is followed by what we call the plateau phase. The plateau phase is where no new symptoms have occurred, yet no recovery has happened yet either. So the patient is left with these symptoms that they have, but they're not getting any better and they're not getting any worse. Generally, the plateau phase with Guillain-Barré lasts about a 2-week period. Then they move into what we call the recovery phase. The recovery phase can begin anywhere from several days from the onset to several weeks, just depending again on how fast the individual moved through the initial phase and the plateau phase. The recovery phase is a gradual process, with some individuals taking 6 months or more to regain their full function again. During the recovery phase, the patient's strength returns in a proximal to distal pattern or a top to bottom pattern. So for example, the last symptoms to appear are going to be the first ones to resolve. Vice versa, the first symptoms that appeared in the individual, which is usually that lower extremity weakness, those will be the last symptoms to resolve. A note about Guillain-Barré is that once a patient does have Guillain-Barré syndrome, once they've had the illness, they actually can't get it again. When it comes to the management of Guillain-Barré, the primary focus is aimed at supporting the ABCs, so your airway, breathing, and circulation. Some other primary treatments are plasmapheresis and immunoglobulin. These are some additional treatment measures, but they're only most effective if done within the first couple of weeks of occurrence of the disease process. So they're going to have the best effects if they're done early on in the disease itself. About 70% of patients have a complete recovery from GBS. Others may have some mild deficits, but overall, about 95% of patients actually survive GBS. Our last disorder that we're going to talk about is Bell's palsy. Bell's palsy is a condition where there is acute flaccid paralysis that occurs generally on one side of the face in an otherwise healthy person. The specific cause of Bell's palsy is unknown, but we do sometimes see it in relation to a recent viral infection, such as herpes simplex or varicella zoster. The highest incidence of Bell's palsy is seen in individuals with a recent trauma as well. We do see Bell's palsy more frequently in patients with Lyme disease. We see it in individuals who are pregnant and those with a recent upper respiratory infection as well. This disease is very frightening to the patient and the family, and so education and reassurance is needed for these individuals. Some of the problems that we can expect them to have is possibly some issues with drooling. The taste buds on the anterior part of their tongue can also be affected. And they're going to have trouble with closing their eye and a drooping eyelid. So moisturizing ointment is usually done to prevent corneal abrasions. An eye patch may be given. They can try some immediate treatment with corticosteroid therapy to reduce the inflammation, and medications such as Zovirax, which is an antiviral therapy, may be given early on, and those may or may not have some positive effects on this. However, the diagnosis is made primarily on the history and physical, and most patients recover without any type of treatment at all. As mentioned, the main things that we're going to be concerned with is the prevention of eye injury or eye damage. And something else is to, keep in mind that they need to try to protect their inner cheek from biting it, as they don't have adequate sensation or feeling on that inner cheek. It's very similar to having your mouth numbed for dental work, where you have a tendency to not realize that you might be biting or chewing on your cheek. So that can cause some additional problems if they were to do that.